Hello, everybody. Welcome to my podcast. Today, we will be discussing part 2 of spine radiosurgery. More specifically, we will look at some practical physics consideration for treatment planning as well as treatment delivery. And so the learning objectives today, essentially, we will look at some fundamental anatomy of the spine. I actually think that in order for you to be a good planner, you should have at least some fundamental understanding of the basic anatomy of the organ you are creating a plan for. This is really essential in, tumor target delineation as well as the delineation of the surrounding organs and ribs. We will discuss the indications as well as the selection of patients for spine radiosurgery. In other words, we're going to look at how patients are selected or deselected from receiving this particular procedure. We will discuss the fundamentals of CT simulation, as well as, in other words, we're going to dive deep into the various immobilization devices that are recommended for spine radiosurgery, why these immobilization devices are recommended, as well as how the state of the patient affects, what we choose to use during CT simulation. Keep in mind that the most common presenting symptom for spine patients is back pain, and therefore back pain in turn limits how long as well as how a patient can be simulated or will be in or on the treatment table. And so we are going to look at the facets of how we could deal with this. Then we will discuss, the recommended, treatment planning techniques for spine cases, as well as look at the step-by-step workflow when actually delivering a spine case in the clinic. And we will look at how online imaging, as well as the various delivery techniques that we have at our disposals in order to treat a spine patient using stereotactic radiosurgery. And so on we go to the basic anatomy of the spine. Now, typically, the spine is usually described by dividing it up into 3 major regions. You have the cervical spine, you have the thoracic spine, the lumbar spine, the sacrum, as well as the coccyx. Now, the cervical spine is the topmost part of the spine and consists of 7 vertebrae. So if you count, this is 1, 2, 3, 4, 5, 6, 7. The thoracic spine consists of 12 vertebral columns. The lumbar spine consists of 5 vertebrae. You have the sacrum and the coccyx. Now, the most distinguished feature that you need to think about the cervical spine is the fact that it has an inward C shape, which is called the lordotic curve, and it allows you to actually turn your head, tilt, nod. On the other hand, the thoracic part of the spine, helps your ribs to attach to the thoracic spine. Now, this section of the spine actually is slightly bent backwards in the form of a C shape called the kyphotic curve. Now, the lumbar spine connects to the pelvis and typically bears most of your body weight, as well as the stress of lifting and carrying objects. Most common back pain occur in the lumbar spine, and so whenever you are lifting something heavy, your posture, how you lift it, actually matter. Otherwise, over time, you could actually injure yourself and find yourself in a precarious situation. Now, the sacrum itself connects to the hip, it actually has 5 sacral vertebrae that are fused, during when the baby is still developing in the womb, which means that they really cannot move. The coccyx has 4 fused vertebrae, that makes up this small piece of bone at the very bottom of the spine. Typically, the pelvic floor muscles and ligament are attached to the coccyx. Now, when you look at each vertebrae itself, it can be divided up into several important parts. The body of the vertebrae is the primary area that bears the weight and provides a resting place for the fibrous discs that separate each of the vertebrae. You have the lamina that actually covers the spinal canal, and typically this is a large hole. The hole is called the vertebral foramen, that at the center of the vertebrae through which the spinal nerves and the spinal cord goes through. You have separating the vertebral body and the transverse processes are the pedicles. Keep in mind that the pair of transverse processes are actually oriented about 90 degrees to each other and provides a point of attachment to back muscles. Now, the spinous process really is the bone. If you run your hand down the back of your spine, the bones that you feel at little intervals as you go down is the spinous process. And so this kind of summates the typical basic anatomy of the spine. So the spinal cord actually begins at the level of the foramen magnum and extends down or ends around the level of L1 and L2, from which the coda equina proceeds. Now, what you need to take note is the fact that when we use the term spine tumors, it is essentially a very broad term that includes both primary and metastatic tumors. Only a minority of spine tumors are primary tumors. This includes vertebral column tumors, intradural, extramedullary tumors, as well as intramedullary tumors. Now, the metastatic disease to the spine are actually much more common. About 225,000 new cases per year in the United States are typically seen, or greater than 25,000 new cases per year are typically observed. Now, primary spinal tumors such as chordomas, chondrosarcomas are pretty rare typically. And so for primary tumors, they can either be classified as benign or malignant. And the common benign spinal tumors include things like meningiomas, you have the schwannomas, and the neurofibromas. A common example of malignant spine tumors include things like you have the malignant nerve shield tumors, you have the oestrogenic sarcomas, chondrosarcomas, and chordomas. Now, what you need to keep in mind is that the most frequent initial symptom for spine cases really is a gradually worsening constant, focal back pain, and sometimes can even be unresponsive to rest and may actually be severe at night that it forces some patients to sleep in a sitting position. We also have extremity weakness, as well as loss of bladder and bowel function. And so for spine metastasis, typically spine metastasis favors the vertebrae simply because it really has a reservoir of large volumes of blood that slowly courses through, the bidirectional venous channel, or what we call the Batson plexus in the epidural space. And this, reservoir of blood supplied through, the vertebrae itself has a high concentration of growth factors in the bone marrow. And so this really act, like a fertile ground for or favor spine metastasis. About 70% of symptomatic lesions are found in the thoracic region. Obviously, that's reasonable because the thoracic spine is the longest, has 12 vertebrae. And then 20% are in the lumbosacral region, 10% in the cervical. Now, the exception here is the fact that prostate and ovarian cancer metastasis typically favors the sacral and the lumbar spine, usually spreads through the, the Batson plexus, and also because of close proximity. Now, the Batson venous plexus essentially is a system of, paravertebral veins that connects the pelvic and the thoracic vessels to the intraspinal veins. Now, spine itself, the spine metastasis is very common. As a matter of fact, it is the third most common site for metastasis after lung and liver. About 94 to 98% of spinal metastasis involves the epidural or the vertebrae, and we already talked about why it favors the vertebrae more. And typically, have isolated epidural involvement, and this is particularly common in lymphoma as well as renal cell carcinoma, RCC. About 5 to 6% are, intradural extramedullary. About 0.5 to 1% are intramedullary. Now, the common tumors that have a higher tendency to metastasize to the vertebrae are prostate, breast, non-small cell lung cancer, renal cell carcinoma, and gastric cancer. Now, like I did discuss before, about 70% of metastatic spine symptomatic lesions are found in the thoracic region, which makes sense. It's the longest spinal region. About 20% in the lumbosacral region, which is the second longest, and about 10% in the cervical region. Now, the cervical region itself is trickier to plan because of the fact that it is very easy for the patient to flex his or her neck, and that actually can pose or introduce dosimetric as well as setup errors during treatment delivery. So we will kind of, go into a little bit details as to how to avoid that with the use of appropriate immobilization device and some treatment planning techniques. And so, based on the International Spine Radiosurgery Consortium, the vertebrae is divided into 6 sectors. You have sector 1 typically is the vertebral body. Sector 2 and 6 represents the pedicles. Sector 3 and 5 actually represents the transverse process, and sector 4 represents the spinous process. And so this actually guides us or gives us some guidelines as to how we can delineate, the target, especially given that it is always found within the vertebrae. And we will talk about this a little bit more detail later. How do spine patients present? The early symptoms, about 95%, usually will present with gradually worsening focal back pain, and sometimes even unresponsive to rest that may force some patients to sleep in an upright position. And And typically this actually, the fact that the patient cannot lie down is already an eliminating factor for that particular patient to be able to receive radiation therapy. Because in order for the patient to receive radiation therapy, the patient needs to be able to lie down in order for us to administer the treatment. Late signs include, radicular pain. And radicular pain itself is a kind of pain that typically radiates from your back, typically in the lumbar region, or most common in the lumbar region, and hip, as well as it moves into your legs through the spine. Now the pain actually travels along the spinal nerve root, and can usually be accompanied by numbness, tingling, or muscle weakness. And radicular pain occurs is really an indication that the spinal nerves are being compressed or pinched or inflamed. Now, other late symptoms that you could see are neurologic complications. You have, myelopathy as well as reticulopathy, and typically this is an indication that the spinal cord is being compressed. And keep in mind that pain typically precedes sign of spinal cord compression by about weeks or months, and once the cord itself is compressed, it almost always rapidly progresses. Typically almost always rapidly progress. Now, what's the typical workup for a spine patient? One thing that you need to note is that in general, labs are typically not required except in cases where the adjacent viscera are invaded. But comprehensive, history and physical examination is typically completed with emphasis on pain as well as neurologic function. Now you could see some of the questions that the oncologists or typically answer, but the focus here is on pain, and typically the pain score is an indication of the grade, as well as it is used to classify as to whether the patient is appropriate to receive stereotactic radiosurgery or not. Now, for the imaging workup, it is really crucial to determine the extent of the cord's inversion, bone retropulsion, as well as the compression of the spinal cord or the coda equina. And so for all spine patients, typically for all spine patients in most centers, an MRI of the spine with and without contrast, as well as a CT, is ordered. Now, there are special circumstances in which the patient cannot do an MRI, and typically these are post-operative patients with metal implants such as pacemakers. In this particular case, a CT myelogram is often preferred. Now, typically we have sagittal T1 weighted as well as STER. STER is simply fat suppressed T2 weighted images. Axial T2 images are used to evaluate epidural disease as well as to contour the spinal cord. Volumetric T1 and T2 typically used for treatment planning. Now, even though the MRI has a superior soft tissue contrast, it is not always the best thing in every case. As a matter of fact, CT delineates the primary bone better than an MRI. Just a little bit of basics for spine MRI. The typical protocol for a spinal cord MRI includes a contrast, typically gadolinium enhanced T1 and as well as T2 weighted sequences, both in the axial and sagittal plane. Bear in mind that in T1, fat appears bright, and in T2, water and fat appears bright. Now, what this implies is that if you look at a T1 weighted image and a T2 weighted image, in a T2, the cerebrospinal fluid is actually more bright. And so if you look at these images here on the board, the very first image is a T1 weighted image, and in a T1 weighted image you could clearly see that the spinal cord here appears dark. If it was a T2, the spinal cord would appear brighter because the cerebrospinal fluid actually is brighter in T2. L2 here, you could clearly see that this particular patient has multiple levels of spinal involvement, and typically here at L2, you could actually see the collapse with epidural fluid extension. As you can see now in B, this is a CT image in B, and you can clearly see that the bone destruction at the level of C2 is very, very visible and demarcatable in CT image as compared to an MRI. So an MRI is not always good. It has a superior soft tissue contrast, but it doesn't mean that we have to use it in all cases. Now, before we go on to the next slide, here are a couple of things that I would like for you to bear in mind. One, vertebral metastases are often hypointense in T1 images, relative, to the normal bone marrow, but T1 weighted images with gadolinium normalizes, the tumor appearance, typically by increasing its intensity to that of normal tissue bone marrow. Now, for STARE, which typically are fat suppressed images, they are actually exquisite. They provide exquisite sensitivity to, study the pathology within the vertebral bodies. So, if you look at this image, A is a T1 weighted and B is a T2 weighted images. You could clearly see that the spinal cord you could see the difference between the spinal cord, the epidural fluid, as well as the vertebrae. So T2 is great to delineate the spinal cord as compared to T1. Now, if you look at T1, you could see the vertebrae involved, as well as the extension into the epidural space right here, and this is clearly visible in T1 images. Spine metastases or spine tumors really are classified based on the Bielski classification, in which it is divided into from grade 0 to grade 3. Now, before we proceed, grade 2 and 3, patients with grade 2 and 3 really have their condition has actually progressed from pain to spinal cord compression. Now, the distinguishing difference, if you look at grade 2 and grade 3, is the fact that in grade 2, there is cord compression with preservation of, some cerebrospinal fluid. And so there is still, some cerebrospinal fluid visible around the cord. But for grade 3, essentially, there is no cerebrospinal fluid that is visible around the cord. And patients with both grade 2 and 3 are recommended, for surgery before administering radiation therapy. Now, grade 1, only the bone is affected. It's just simply a bony disease, and so only the vertebral body is affected. This is a really great candidate for SRS. For grade 1A, we have a little bit of epidural impingement without the deformation of the thecal sac. This is the spinal canal. This is the spinal cord. There is for grade 1B, there's a little bit of thecal sac deformation, but there is no contact with the spinal cord yet. But grade 1C, the thecal sac is actually deformed and the spinal cord is actually in contact. Now, in the consequence of the progressing grade is that it as it progresses from grade 0 towards grade 3, we are heading towards cord compression. And the closer the tumor or the target is to the spinal cord, makes it really dosimetrically challenging in planning this particular case, because the spinal cord itself is a serial organ, and it is an important organ, and it is a dose limiting organ that typically limits the dose that we could typically limit how much we can escalate the dose to the target. We will look at this a little bit more in detail. Now, this is another way to represent this. You can clearly see that for 0, only the bone. 1A, you have a little bit of epidural impingement. 1B, look at 1B, the thecal sac is deformed, but the spinal cord is not aborted. 1C, the thecal sac is deformed and there is spinal cord abortment. It's really clearly shown here. Grade 2, we still have, the CSF is still very visible, and grade 3, there is little or no CSF left, and this patient is in great pain. And so, just a word of caution here, when spinal cord compression happens, the patient is in excruciating pain, and the pain only worsens with time. Typically, cord compression leads to edema. It leads to venous congestion as well as demyelination. And if the compression is of short duration, the effects can be reversible. Things like remyelination as well as the recovery of function is possible. But however, if cord compression is prolonged, secondary vascular injuries will eventually occur with infarction of the spinal cord, and there is really no meaningful recovery in this particular case. And so, to summate this, spinal cord compression is an emergency and should be treated as an emergency. And so, grade 2 to grade 3 typically requires, a separation surgery before radiation therapy. And so the question then remains, what are the various treatment options available for spine patients? Now, a couple of factors are used by the oncologist and the physics team in every center to decide what patient receives spine stereotactic radiosurgery and what patient doesn't. And so if you look at this table, we could classify spine cases into low grade, that is grade 0 to grade 1, or high grade, that is grade 2 and 3. Now, if it is low grade and the histology is radiosensitive, before I proceed, one of the most important determining factor for all spine cases is spinal stability. If the spine is not stable, the patient will not be able to lie still on the table. And so it makes no sense to treat a moving target. because we are delivering a very high dose, and so it is paramount that we immobilize the patient. And if we cannot immobilize the patient, it automatically disqualifies the patient to be able to receive spinal radiosurgery. And so the mechanical stability of the spine is often one of the main goals when we do a comprehensive history and physical examination of every patient. And so if the grade is low grade, or if the tumor is low grade and radiosensitive, if the spine is stable, then we can offer radiation therapy. But if the spine is mechanically unstable, then typically a stabilization surgery needs to be completed before radiation therapy. Now, if we have a low grade, either from grade 0 to 1, and the spine is stable, but the histology is radioresistant. Typically, radioresistant histologies originate from renal cell carcinoma. And so if we have a radioresistant histology and the spine is stable, then stereotactic radiosurgery is recommended for the patient. But if the spine is not mechanically stable, then stabilization surgery must be completed before stereotactic radiosurgery. Now, for high-grade, lesions, typically grade 2 and 3. Now, if the lesion is radiosensitive and the spine is mechanically stable, then conventional, radiation therapy is offered to the patient. Now, if the spine is not stable, then stabilization surgery needs to be completed before external beam conventional radiation therapy is given to the patient. Now, if the lesion is radio resistant, and the spine is stable, then separation surgery needs to be completed before SRS. Keep in mind that for grade 2 and grade 3, where the lesion itself is aborting and compressing the cord, surgery needs to be completed first before radiation therapy. That is the recommended route that is used in these cases. And so when we look at a spine case, what then can we say? The common and the most ideal indications. The ideal indications for spine SRS therefore includes: 1, patients with no prior history of radiation, oligometastatic disease limited to two or less disease, and as well as with no epidural involvement, radioresistant histologies, 3 or fewer spine segment involvement, a mechanically stable spine, as well as a low-grade disease. And so to end this, when the oncologist is evaluating a patient or making his recommendation, he looks at factors such as the severity, the type and the duration of pain, the neurologic status, performance status, the patient's preference, disease burden, tumor histology, whether it is radioresistant or radiosensitive, and it's actually a function of where the tumor metastasized from, as well as the treatment factors include things like the location of the tumor in the spine. Is it in the C, lumbar, sacral, thoracic spine? Is the spinal cord mechanically stable? Has the patient received prior radiation therapy, and so on and so forth? So these are some of the factors that are used So how does this work? Just briefly, the primary rationale for spine stereotactic radiosurgery is to deliver a significantly higher biological effective dose, which in turn improves local tumor control as when compared with conventional radiation therapy. And there are, lots of published evidence, demonstrating the efficacy in using stereotactic procedure in the treatment of spine cases. One of the ROTG reports, 0631, actually discussed this in particular details. I recommend that you should take a look at those. And so, to summate these, the biological effective dose for 8 Gray in 1 is so much higher compared to 2 Grays, giving 2 Grays in 9 fractions. So the whole big concept here is that SRS delivers a higher BED, which in turn improves drastically the local control of the disease. And so the typical workflow for a spine patient is once the patient is referred to an oncology department, CT simulation is conducted, MRI images are ordered, then the CT images are then fused with the MRI images. When this is completed, both the target and the surrounding organs at risk are delineated. Once the target and the surrounding organs at risk are delineated, then we now put in the objectives, that is the dose prescription and the dose constraints for the surrounding organs at risk, and then develops a plan. The plan is then reviewed by both the physicist and the physician. Once the plan is approved, then either PSQA or patient-specific QA is completed. In our clinic, we do both a point measurement with the use of a small volume ion chamber, such as a pinpoint ion chamber, or sometimes if the lesion is too small, we use a PSD. As well as we also do, the fluent measurement to compare the dose distribution between the plan and the delivered with the use of film. If once the PSQA is completed, analyzed, and it passes the gamma criterion, then the patient is treated. And we are going to look at the workflow during treatment delivery in a little bit. And so for simulation, the kind of immobilization device that we use depends on the location of the vertebrae that we are treating. And so if the vertebrae is located along the C-spine, we will use a different immobilization device as opposed to when the vertebrae is located along the thoracic or the lumbar spine. Now, the fundamental principle in immobilization is to promote two things: patient comfort and reproducibility. And so the natural principle, the fundamental principle that governs immobilization, it states that the patient's natural tendency is to fidget or move during treatment. And so, in order for us to treat the same target or irradiate the same volume with the same beam arrangement in every fraction, we need to immobilize the patient. And in order for us to be successful, we have to keep the patient as comfortable as possible. A more comfortable patient is less likely to move during treatment. And so we always aim to make the patient as comfortable as possible, as well as to use the proper immobilization device to keep the patient still in the course of treatment. And for C-spine cases, in our clinic, we use the Q-Fix overlay board. We have the 9-point thermoplastic mask, sometimes with the use of shims. We have a headrest. You can clearly see that under the patient, as well as we also, depending on the comfort level of the patient, use a hand grip in order to have a more reproducible position. And the diagram here doesn't show, we have often used an ankle sponge, to make the patient as comfortable as possible. Now, when we are simulating a patient with a C-spine vertebrae, we typically set our table vert to 150 cm, and this actually varies from center to center, from machine to machine. The CT slices that we typically use, the slice thickness that is recommended is 2 millimeters. You can actually go to TG 101 to look at the recommended CT slices, and the common field of view width that we use typically ranges from 350 to 400 cm. Now, the whole rationale to use the appropriate field of view is to image the vertebrae and at least 10 cm inferiorly and right up to the end of the scalp. And so remember, when we're doing the CT simulation, the length of the field of view is chosen such that 10 cm below and above the tumor is imaged. This is to give us sufficient anatomical information in order for us to get an accurate dose calculation. Now, for thoracic spine cases, typically from T5 to about L5, we use a full body backlog back. We use a plastic shield now and a suction system. Typically, the way the blue back essentially works is that it has really miniature beads inside the bag. We lie the patient, we place the bag on the couch, place the patient in a very comfortable position, typically with the use of an ankle sponge for leg support and to improve patient comfort. And then we mold the bag to conform to the shape of the patient. Once that is done, the air in the bag is actually vacuumed out. When the air is vacuumed out, the beads lock in place and preserves that position for every fraction. Now, the good thing about using the backlog blue bag is that it is reusable, and so it's really different from the alpha cradle where it is only used once, and so it is much more cheaper and economical, especially for centers with a large patient load. Now, the vacuum plastic shield essentially is to lock the patient in place and to prevent fidgeting or movement as much as possible. And if it's possible, when we are treating a vertebrae between T5 and L5, we kind of simulate the patients with the hands above the head holding the ring. Typically, we want to take the hands or the arms away from irradiation beam. If we simulate the patient with the arms running by the side, depending on how we plan the patient, we're going to irradiate the arms, and that itself will introduce dosimetric errors in the calculation of the dose delivered to the patient due to attenuation. And by the way, if we can move the arms out of the beam, we just want to irradiate as little healthy tissues as possible. Our objective here really is to hit the target as hard as we can, as well as to spare the surrounding organs at risk. Now, from T-spine, T5, right down to the sacrum, from T5 right down to the sacrum, we simulate the patient with a VAG-lock, full body VAG-lock blue back. We have the plastic shield and the suction system. What you need to keep in mind is that we use, a short medium ankle sponge in this particular case, for the patient to be a lot more comfortable. And the same principles apply here as explained before. Now, as opposed to, C1 to T4, the table height in our center stays the same. It really depends on the machine you're going to treat the patient at about 150 cm. The field of view is 600 cm. The width is 600 cm. Now, the length of the field of view is chosen such that at least 10 cm superior and 10 cm inferior to the tumor is included in the anatomical images. And this is so as to give us sufficient anatomical information in order to produce an accurate dose calculation. And so, how do we delineate the target? At Henry Ford, we actually follow RTOG 0631. And the target outlined based on these guidelines. If you have not taken a look at it, it is actually a very important document for you to look at if you want to ramp up your knowledge on how spine radiosurgery is done. Most spine metastases involve the vertebral body. We already discussed that before. And if you look at figure A, as you can see, the solid black represents the tumor, and the red contours here represents the target that actually involves the vertebral bodies as well as both the right and the left pedicles. When the metastasis involves only the posterior element, the target volume includes the spinous process as well as the laminate, as you can clearly see in C. Now, per recommendation of RTOG 0631, there are no planning margins for spine cases. As a matter of fact, the PTV is the same as the CTV with no additional margins. And so the target as defined is not or will not be enlarged. What you need to keep in mind is, as we go forward, is that at our center, the PTV is the same as the CTV with no additional margins. And typically, the CTV is defined as the whole vertebral body, plus or minus the pedicles, plus or minus the posterior elements, depending on how the tumor progresses. And typically with the exception of, metastasis located mainly in the posterior element. And when that happens, we need to include, all epidural as well as the paraspinal involvement. It is recommended by high-tech reports that we need to draw a PRV around the cord, which is often defined by, a T2 weighted MRI or a CT myelogram and the margins for the TRV is about 1.5 to 3 millimeters. Some centers, instead of contouring the cord, contours the thecal sac, and it actually takes care of the fact that the thecal sac engulfs the cord, which provides a little bit more flexibility and to take care of the setup errors. And so the consensus guidelines used in contouring the target is shown on the slide. As you can clearly see, as discussed previously, these are examples, actual examples of clinical cases that have been contoured with the use of consensus guideline. Now, in these three cases are actually pretty challenging to plan, because essentially the vertebral bodies, both the transverse as well as the spinous process and the pedicles, are all involved, and so we want to spare the cord which is found at the middle of the target, and so this is quite an interesting plan to complete. Per RTOG 0631, the spinal cord needs to be treated with special care when we are doing spine planning. Now, the conventional spinal cord volume is contoured on a CT simulation based images that are fused with T2 weighted as well as T1 weighted MRI with contrast. Now, per RTOG 0631, it is recommended that a simulation CT be done with contrast, but this is not required. It is a recommendation but not a requirement. Now, the conventional spinal cord should be contoured at least 10 cm above the superior extent of the target volume and 10 cm below the inferior extent or below the inferior extent of the target volume. Or keep in mind that because of the steep dose gradient that is required, because the cord is so adjacent to the target, any slight motion during treatment will have devastating consequences. As a result, a PRV around the cord is often recommended for additional safety. Now, RTOG 0631 also recommends a partial cord, and the partial cord should be contoured starting from about 5 to 6 millimeters above the superior extent of the target and to 5 to 6 millimeter below the inferior extent of the target. Now, the dose constraint to the partial cord is 10 gray to no more than 10% of the spinal cord volume as defined from 6 millimeters to above to 6 millimeters below the target. The absolute cord dose is 10 gray to the spinal cord volume to less than 0.35 cc's. Now, I cannot overstress this because of the high possibility of setup errors in spine cases. Because of the high possibility of setup errors in spine cases, a safety margin is required, and typically we apply a uniform planning OAR volume of about 1 to 2 millimeters around the spinal cord itself. Or some centers uses the thecal sac as a surrogate structure for the cord. Now, the dose prescription. Now, per recommendation of RTOG 0631, the plan is prescribed to the periphery of the target such that at least 90% of the target volume is covered by the prescription dose. and the plan is typically normalized to the target center. Now at Henry Ford, we often get at least a minimum of 97% or better coverage in most of our cases. And the OARs that we use have been outlined in TG 101 as well as in high-tech reports. And the common prescription that we see are 16 to 24 grays in one. You have 10 to 12 gray in two fractions, 9 in 3, 6 times 5. Now, before we proceed, I want to make a few comments here that are important. The dose prescription is governed by a variety of factors. One of the factors of consideration is the goal of treatment. Are we looking for local control, or are we looking for symptom management such as pain control? The histology of the tumor matters. Is it radio-resistant or radiosensitive? Also, the proximity and the presence of critical normal structures such as the spinal cord needs to be taken into consideration. If we have epidural involvement that aborts the spinal cord, then it is very difficult for us to meet our dose constraint if we use a single fraction. In such cases, we could either use 9 times 3, or we could use 6 times 5, or maybe 12 times 2. And so the treatment planning technique that we use, mostly triple F beams are preferred in radiosurgery. And the reason triple F beams are preferred, especially for spine cases, it's because it comes with a much higher dose rates. In our clinic for our machine, the 6 triple F, we do 1400 MUs per minute and 2400 MUs per minute for our 10 triple F. This means that the treatment time is drastically reduced, and this is very important as 95% of patients with spinal tumors are experiencing some sort of pain, and it makes it really hard to lie down straight and for a long period of time on the treatment table. We can either use techniques such as VMAT, IMRT, or dynamic conformal arcs. And so whether we use IMRT, VMAT really depends on the location of the tumor, the proximity of the surrounding organs at risk, as well as the geometry of the nearby structures. I'm going to talk about that a little more. Now, for IMRT, typically we have about between 9 to 14, coplanar fields arranged laterally and posteriorly, typically mostly posteriorly. About the dose grid that is recommended by TG 101, it should be less than 3 millimeters. But at Henry Ford, where I am as a resident, we use 1.5 millimeters. The thing about the dose grid is the smaller the dose grid size, the more accurate the dose computation accuracy, which also implies that the gradient will be steep enough and the dose will be more conformal to be able to spare the cord, which really is what we want. But the downside of using a smaller grid size is the increase in computational time. And so the beam arrangement, like I said, depends on the target shape and the position of the target with respect to the spinal cord. VMAT, typically we use about 2 to 4 arcs at a couch angle. I love to use a couch 0 to prevent collisions, but sometimes, if depending where we are treating, if we are treating maybe a C4 down to T5, then we will run into problems if we use a coplanar arc that the beams will go through the shoulders. Because the beams will go through the shoulders, it will increase the attenuation of the beam, which in turn will decrease the accuracy of our dose calculations. In order for us to deal with that, we use a couch kick to kind of orientate the shoulders and put them out of the field, or we could actually adjust the collimator angle to prevent the beam from going through the shoulders and the chin, because it will introduce errors in our dose calculations due to attenuation through the structures. And so really, the only other thing that I think you need to take note are: 1, try to use non-zero collimator angles. 90 is great because most often the vertebrae is some sort of this shape, and so when we rotate our collimators at 90, it will actually limit the exposure of the spinal cord to spilled radiation, or to spilled dose. And that often works pretty much great. Remember, slight couch kicks are used to avoid, tangentially shooting through the patient's shoulders for lower C-spine and upper T-spine cases. Now, in order for us to design a good plan, what is often recommended is for us to use planning tuning structures. Typically, the dose conformality to the target, the heterogeneity, as well as the dose gradient away from the target are critical parameters in spine radiosurgery. We want the dose to be conformal to the target in order to spare the surrounding organs at risk. But also, because of the proximity of the cord and other OARs, we also want a steep dose gradient. Typically, the decline from D90 to D20 occurs in about 1.5 to 2 millimeters. And so, because of the need for a steep dose gradient, in order to achieve this, we use tuning structures. And these tuning structures are essentially ring structures that are placed around the target volume. Sometimes they could abort the target, or a small offset from the edge of the target in order to promote, dose conformality to the target, dose heterogeneity, essentially by forcing the hotspot to be inside the target using a central ring structure within the target, as well as a high dose gradient around the target ring with the use of concentric rings. And so, to summarize this slide, dose conformity to the target and dose gradient away from the target are critical in a successful spine plan. Tuning structures or planning structures are used to promote 1, dose conformality, as well as to evaluate the plan after it is completed. Additionally, we use concentric rings around the target to modulate or to force the dose gradient around the target in order to meet our dose constraints. And so in these examples, you could see here the inner circle. This is what we call the TV central. This is TV 5 millimeters to OARs. This is the outer ring. This is the inner rings. And I'm going to do an example in the next podcast and show you how to create these structures. And so typically for a spine case, the PTV is broken down into 3 rings. You have TV central, which is the central ring. You have TV ring, which is the outermost ring, and you have TV 5 millimeters to OARs, essentially, which is the portion of the PTV that is 5 millimeters to the cord or coda equina or the spinal nerves. Now the function of these 3 rings is to do one thing: promote the hot spots to move to the center of the lesion, and secondly, to promote heterogeneity within the lesion. We have 2 outer rings. You have ring out and ring in, and the outer rings, this is ring out and this is ring in, essentially is to promote a better conformality index and a better gradient index, while the inner rings within the PTV really is to promote a good heterogeneity index. Now, in a case where the PTV itself is almost aborting an important structure such as the cord, sometimes we create an optimization structure which is essentially the PTV and crop maybe up to about 3 millimeters away from the cord. Now, when we do this, we then force the dose to the PTV up to be the prescription dose, and the dose to the normal PTV to be a little bit less. This in turn will decrease the dose between the PTV and the cord, and also improve a steeper dose gradient, and so thereby sparing the cord. And so the typical spine treatment, we often, after the patient is set up on the table, depending on what spine we are treating, if it is if it's between C1 and T4, we use a 9-point thermoplastic mask. But if it's T4 right down to the sacrum, we use a full body black, a vacuum, a sheet, and the suction system to lock the patient down. Once the patient is set up, the very first thing that we do here at Henry Ford is that we do take a CBCT image. Now, this CBCT image, we do a bony match, and then we do a soft tissue match. Once this is completed and approved by the physicist and the physician, then we do a verification image, which can either be a KVMV or a CBCT. Now, the verification image is very essential because it takes approximately about 7 to 15 minutes to complete a CBCT and apply the sheaths and make sure that everything is correct. And given the fact that this patient is really in pain, there's a higher probability that the patient might move in the course of the process. And so we take a verification match to ensure that the position is still accurate. Now, if we meet the tolerance, which is typically less than or equal to 1 millimeter, 1 degree, then we treat. But if the tolerance, if the sheaths that needs to be applied are greater than 1 millimeter, it means that the patient shifted. And so we will redo a CBCT and apply the sheaths. And sometimes we can even go into the room and readjust the patient's position. During treatment, We need to constantly evaluate the position of the patient because it is critical given how close the cord is to the treated area, and so we do trigger images during treatment. And if we are using VMAT and different arcs, sometimes we do a mid-treatment KV-MV or CVC, that's between every arcs, to make sure that the position is still as good as it was after the patient was set up and aligned with the use of online images. And so this really is a comprehensive, complete process with a feedback loop for us to make corrective adjustments to ensure that the positional accuracy of the patient is maintained. Thank you so much, everyone, for staying with me throughout this podcast. I look forward to the next podcast. Bye-bye.